All right, has this ever happened to you? Just look at this little GIF while I explain what's going on. So if you have diabetes, then it can result in overflow incontinence, and this is caused by diabetic autonomic neuropathy. That's affecting the detrusal muscles and their innervation. So, or rather the innervation of the detrusal muscles. So there is a damage to the autonomic afferent innervation, so you cannot sense a full bladder. It's there, it's full. You can't sense it though, because the afferent innervation's gone. And so there's a damage also to the efferent fibers to the detrusor, which means you have incomplete emptying, and so the bladder is overdistended. And so there's stress, there's urgency incontinence, there's mixed incontinence, and overflow incontinence. And I'll mention all of them briefly. Yeah, we'll do that real quick. Stress incontinence. Let me just go ahead and paste this for you so you guys can follow along here. This is a good little chart. Boom. All right, so here's our chart. Stress incontinence is leaking with the Valsalva maneuver. That's coughing and sneezing, kind of like we see here, stress. All right, and then we have urge. That's the sudden need to void. Bladder training you use for that. Also mirabegron and beta-3 and M3, I believe, muscarinic 3. Anticholinergics like oxybutynin is used for treatment. Mixed incontinence. It's going to be features of both of them, both the stress and the urge, and has variable treatment. And outflow is going to be constant involuntary dribbling and incomplete emptying. And so there we go. We'll dive into this question now. A 62-year-old man, 15 history of type 2 diabetes, dribbling of urine, and a feeling of incomplete bladder emptying. Post-void bladder scan shows high residual volume. What is most likely the cause? All right. So our correct answer is going to be bladder autonomic neuropathy. And so what's happening here is we know in chronic diabetes you can cause damaged nerves. That's autonomic neuropathy. Cool. So now what happens is that the afferents and the efferents are both kind of damaged in this case. And so it's overflow incontinence due to the impaired bladder sensations and detrusor underactivity. That's what's going on here. Detrusor overactivity, that'd be urge incontinence. That's a sudden urge to pee all the time. BPH BPH is B. So that's possible, but it's not as classic without an enlarged prostate on the exam. They'd have to show you and say that's what's happening. Increased pelvic floor tone, that would cause retention, but not seen in diabetes. Stress incontinence would be the laughing and the coughing and this guy, stress incontinence. And then you pee. All right, so overflow is when the bladder gets too full and it leaks. It's like a cup overfloweth. You don't feel the urge, it just kind of dribbles out, right? And so in diabetes, this can happen. And so diabetes, nerve damage, bladder can empty. That's pretty much the gist of it, right? And so yeah, overflow incontinence. That's what's going on here, and that's pretty much it. Increased post-void residual and catheterization and ultrasound. This is just a really good chart to look at. Features of both stress, it would be mixed, and then overflow. So polyuria, here it is in diabetes. You ever see those commercials? It's like, are you diabetic? Do you have to go to the bathroom all the time? It's one thing you got to watch out for, right? So yeah, bladder outlet obstruction, also BPH could be causing this, involuntary dribbling and incomplete emptying. Overflow incontinence, and then our stressors like our coughing, Valsalva maneuvers, our urgencies is like, oh man, I gotta go. And so you just got to relax that, so you don't have to go as much. That's how you treat it. Pessary and also pelvic floor is good for stress incontinence. That's usually the answer, like Love Vader Annie. They love that for some reason. All right, we'll see you in the next vid.